Okay, everybody. So we're going to start now. My name is Samantha Andrews. I am the training manager with CATCA, and this is the Wednesday webinar series. We have this on a monthly basis, and it's on trending topics that different communities, coalitions, and anyone who is interested in resources related to drug prevention. Of course, this has been a popular topic with the current opioid crisis. So we thought, what coalitions need to know about the Opioid Response Network, a great partnership we had with ORN, would be a great topic for today. For our Wednesday webinar series, it's somewhat like a lecture style. So we'll have a portion at the end of each presentation, one with Sarah and the other with Catherine, to take Q&A questions. We'll have them in the Q&A chat box, but also in the chat box itself. So if you have questions, I will hold them till the end and read them off to the presenters. Can you go to the next slide? So this is just some general housekeeping. I'll also put this in the chat. Don't forget to put about the Q&A box, also to make sure you pose it to everyone so everyone can see them. As I mentioned, Wednesday webinar series is part of CATCA's monthly sessions. We have a webpage on CATCA where you will be able to access these slides and also to access this recording. That will be posted in the coming days, probably Monday, if you have anyone who was unable to attend and still wants to reference this back in the future. At the end of this webinar, there will be an evaluation link, and we'll have a participation letter that will be emailed to you once you complete the participation link. Next slide, Sarah. So today's objective, we will show you how to facilitate discussion with your coalition on priorities and challenges in combating opioid misuse, engaging sector partners in treatment and recovery, and identifying key beneficiaries of ORN training and TA. Participants will be able to see how to pinpoint top priorities that foster focused action. Next slide. And of course, introducing our first presenter, Sarah, and please correct me if I mess up your last name. I'm the worst at last names. Cavancy? Please correct
me. You're good. I take anything except Kennedy.
Okay. Too fancy. I don't have the ability to speak that fancy. She is a part of the Opioid Response Network team, which provides training and education in prevention, treatment, and recovery to organizations and communities addressing opioid and stimulant use. Sarah has her bachelor's in journalism and a minor in event planning and her master's in public health. Wow, that is very eclectic. You do it all, don't you? She has combined these skills over the last 10 years to engage and educate audiences around tobacco use and mental health and opioid use. She is our first speaker today, so I'm going to hand it off to her. Again, please use the chat box. I'll be monitoring that, and let me know if you have any questions. Hand it over to you, Sarah.
All right. So I'm going to start with a video so that relieves the pressure off of me. So let's fingers crossed it works.
Communities across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.
Okay. So as they stated, we're across 50 states. I'm in Washington, so I cover Washington, Oregon, Idaho, and sometimes Alaska. Like, you know, that's what I do. So the first thing I want to talk about is like our funding and how we work. So SAMHSA funds the Opioid Response Network to help provide resources and technical assistance to address the opioid and stimulant use crisis. Across the nation, each state and territory has a designated team. And what we do is provide education and training in response to the opioid crisis on request. The Technical Transfer Specialist, or the TTS, manage these requests. So the TTS role and responsibilities include project management, to coordinate and track TA requests. We manage TA teams, we schedule meetings, we maintain communication channels, we assist TA teams in matching evidence-based practice and implementation strategies to fulfill TA requests. And as we kind of go through this presentation, I'll talk a little bit more about each of those teams and what they do and how we all work together. So we accept requests for education and training. Each TTS manages the requests in their region. Like I said, I got Oregon, Washington, Idaho, and sometimes Alaska. We are currently split into 10 different regions that are aligned with the Health Human Services region. So I'm in region 10. And each region has at least one of me, if not more. Some have more. Along with our 10 regions, we also have a team of TTSs dedicated to tribal requests. They make up the Indigenous Community Response Team, and they're split into 5 different regions. Their priority is tribal requests. Our work at ORN, we really want to make sure that we're being culturally responsive, and the training and education that we're targeting is culturally responsive to the requests. So for that, we have 3 kind of work groups that focus on minority populations: the Black Communities Work Group, Alaskan Native Indigenous Tribe Work Group, and Sexuality and Gender Diversity Work Group. We're also in the process of starting a few others work groups that focus on Asian Americans, Latinos. We're trying to make sure that when we are providing you guys education and training, we're doing it in a responsible way. So these work groups are the ones who can recommend consultants to work with us, because they vet their own consultants to make sure that they meet their standards, and that when we're getting them to do the request, they're able to like talk to the community in a way that is responsive. So I mentioned consultant teams. So each region has a panel of consultants in prevention, treatment, and recovery. So we cover the whole spectrum. We typically use consultants that are local whenever possible, because when we're providing our training and education, it's tailored to you, your area, your state, so that we want to make sure that the person who's providing the education knows what they're talking about. We also are across the US. So if you have a topic that is specialty like harm reduction, because we're across the US, I have the ability to bring in anyone who is interested in working with us to provide that education. So it's not just ground, like I don't just Oregon, right? I can pull from New York if I need to. We also utilize core team partners and national specialists as needed. We are so very lucky to be able to work with our partners that help provide TA with us. We work with the national partners across the US. Some of those partners are like CADCA. We also work with C4 Innovations, Boston Medical Center, National Sheriff's Association. We're actually partnered with 46 different agencies, so we're able to provide a lot of different types of assistance based on different backgrounds. The TTS's goal, my goal, is to find the right fit for you guys. I want to make sure that when we're providing the TA that's specific, we don't just have somebody coming in from out of state and giving examples from their state, right? We want to make sure that we're doing tailored work. So to nutshell everything, our mission is to provide training in TA via local experts to enhance prevention, treatment, especially medications like buprenorphine, naltrexone, and methadone, and recovery efforts across the country addressing state and local specific needs. And the way that you can do that is by putting in a request. We are a request-based organization, so we can only help you if you put in a request. And there's a couple of ways you can put in a request. You can go to our website. You can also email orn@aap.org, or you can call a phone number. I will be very honest. I've never called that phone number. I don't know who's there, but I'm pretty sure somebody will pick up. So if phone is the way that you want to go, I say go for it. So now that you have like all of that information percolating and stuff, what does it mean? So our focus at ORN is technical assistance, and I like to call that fancy language for training and education. And that training and education can look like a ton of different things. We can help educate local coalitions on how to have conversations around stigma, provide language to help explain treatment better. We help provide trainings with CADCA Bootcamp to help build strong coalitions. We also provide strategic planning sessions to help review current policies and procedures. The list is kind of endless. There are a couple of things that we don't do. So we cannot provide you with money. We also can't write a grant for you or make any products for you. But what we can do is review those things. So if you're writing a grant and you would like somebody to help review it to see if you've missed anything very important, we have people who are able to do that. So while we can't make it for you, we can at least help you guys with it. So again, you can go to our website. And then in the top right corner, there is a very big orange button that says submit request. Okay. Like, I'm not even kidding, right there. You cannot miss it. So when you hit that submit a request, you're going to be taken to a Google form. So this Google form, you provide basic information, including where you live in your state. We ask you to verify your state because that is how your request is routed, right? So if you put in Oregon, it'll come to me. But if you put it in Missouri, it's going to go to my co-worker, Sherry, right? So we need to verify where you live to make sure it goes to the right place. Here, right? First, second, and then your zip code. Next, we have you write a description of what you want your TA to be. You don't need to write a book. So I don't need like 5 paragraphs telling me what you're looking for, but I also need a little bit more than just a word. If you say harm reduction, that could mean so many different things. So a sentence or two of kind of what it is you're looking for will help us down the road to make sure that we're providing the right kind of TA. So then we have some more questions. They do ask how you've heard about the ORN. And if you guys decide that you want to do a TA request, you'd hit that first button because you heard it at a presentation where somebody was talking about the ORN. And it's really nice. You don't have to name me. So you can't say that you bumbled your way through a presentation with Sarah. Okay. So then once you go through that, you hit next. And then it takes you to another page to like confirm very firmly that you want to submit this request. So once you hit submit, it is automatically routed to the region you belong in. And once we get the request, so once the TTS gets that request, you will get an email welcome and asking for a time to set up a first meeting to learn more about the ORN and how we can help. So during this meeting, we're gonna look into what you need help with. We're gonna dig a little deeper to make sure that we're gonna address all of your concerns. We will have a better understanding of what you're looking for. And then what the TTS does is submit a summary. And when we submit a summary, it is reviewed and approved. Once approved, we start the process of looking for consultants who we believe will be a good fit, right? There are those this is also where that work group can come into play. So if we have a request that's specifically about BIPOC populations, we would go to our Black communities work group to work with them to find the right consultant to meet the need of the requester. So when we reach out to the consultants, we take the time to provide information to them. We do this in code sometimes. I'm kidding. There's no code. But there is a secret to how we talk about what requests are. So that secret is just how we organize them. And so we identify requests under one of the 3 topics that we cover. So there's prevention, treatment, and recovery. We're also kind of starting slowly to add in some new trainings and education. We focus on some specialized topics. So we've done some trainings and education around harm reduction, stigma, and DEI training. We also take a look at what type of request this is. So we have 3 different types of requests. Universal requests are just requests that are wanting some resources or website stuff to kind of help you kind of look into things. We also have targeted requests. Targeted requests are about building skills. This is where there is a specific goal or outcome that you're looking for that we can help provide. And then there's the intensive request. So the intensive request is building awareness and skills on an organizational level. This is a request that we think will take an extended period of time and require more than one consultant to work on it. A really good example of that is an MOUD implementation. That's going to take us a little while to do, and we'll probably need more than 1 or 2 consultants to get that working. So once we get the consultant to agree to work with us, we set up a meeting with the requester, and then we sort of build out what the next steps are. We work with you on identifying those steps, and we work at your pace. So I know everyone is a rush to get things done, but we can stretch it out. We can try to go small. It just depends on kind of what you're looking for and what type of request it is. And so I'm going to talk a little bit about the different requests and give you guys some examples of what this might look like. So I want to talk about the first request, which is prevention. So the one example is a coalition building. So through a needs assessment, I was able to figure out that this group that had put in a request to help create this emergency public health response plan actually needed to work on their coalitions because they did not have functioning coalitions to create the emergency public health response plan. So we found out that the 3 coalitions, one was running, one was just getting started, and one was not working. I called in CADCA and I asked them very nicely if they would help me, and they agreed. And what we were able to do is we talked with them and decided that the best route would be to create a boot camp. So I don't know if you guys have experienced boot camps, but they're 4 days of intense training and it's very overwhelming. And we're working with this request with those who work in public health offices, they're prevention specialists, they work for the state. There's no way we can get 4 consecutive days off to do this training. So we were able to tailor the training to meet their needs. What we ended up doing is providing 1 training a month that was very focused. And then we provided them with homework. So the homework meant that in between the trainings, they had things that they had to do, and then we would help them work through that. So we were helping them build their coalitions from the ground up. And so we did that over a series of 4 months, and it was great. We did eventually get the emergency public health response plan completed, but before we got there, we had to do the coalitions first. So a next one is treatment. So I haven't yet worked with CADCA doing a treatment, but one day I'm very positive we'll get there. But a good example is that we had a group of behavioral health wanting to implement 5 different MOUDs across Oregon. So what we were able to do is provide reviewing of their policies and procedures. We gave them best practice to build out their programs. We are continuing to work with them. Right now, we are providing training and education around opioids and harm reduction and stigma. And so that's kind of how we work with treatment. We can go in, we can help you build out programs, and then we can also provide training and education so that people understand the new work that they're going to be doing. And the last kind of request that we have is recovery. I'm actually very excited about this request. When we got this request in, it was just wanting a request for education and training, which is what we do. But digging through, what they were doing, looked like that they didn't have all of their coalitions functioning. And this was a recovery coalition group. So their focus was on recovery, and some of the stuff that they do are like recovery days and advocacy days and whatnot. And so half of them weren't working and half of them were. So what we were able to do is, first, I was like, I think we need to work on your coalitions before we can provide training and education. And then I immediately sent an email to Sean and Joy and was like, do you do coalitions besides prevention? And then they laughed at me and said, we do all coalitions, Sarah. So I was like, great, we have a recovery coalition that I want to work with. So what we were able to do is we did some strategic planning sessions with them to look at their standards, to kind of help them build out what it means to be a coalition member with them. And then we are currently providing tailored training that focuses on coalition, but through the scope of recovery, so that we're able to provide this education, and we're using the language and the information and knowledge that recovery is, so it's tailored specifically for their needs. We are not done working with them. We're continuing to work with them. We are actually getting ready to do our 3rd training, and it's so exciting to see this group kind of grow. And they're also like have renewed their passion for coalition building. So the first one, no one talked. The second one, we finally got people to engage with us. This 3rd one, I'm hoping somebody will dance. Maybe we'll see what happens. But that's kind of recovery, and those are like the 3 main ones. But we also do have specialized trainings. And that can be harm reduction, stimulant, stigma, and DEI training. So some examples, we're providing harm reduction education for a judge who is interested in bringing harm reduction policies into the courtrooms in Oregon. So we're helping him provide education to a group of judges. Stimulants, the treatment for stimulants is contingency management, and we're helping a group build out a contingency management program. Stigma is always there, right? So we do lots of education trying to break down that stigma and get people engaged and understanding more about what's going on. And then DEI training, we are working with a peer group to look at their standards and policies that they have in place and how they can look at it through the scope of their diverse clients and clients that have had problems with opioid addiction. So it's a very special scope, and they want to make sure that they're reaching those people in a way that is not being alienated. And so to end this wonderful presentation, the best thing about working with ORN is that we help our requesters from asking for resources, all the way to implementing programs. Our goal is always to provide you guys with best practice and data-driven information. We really want to focus on not recreating the wheel. We know what works because we know best practice, and we want to help you help others. So that's really what we are doing and what we hope to accomplish. And I'm done.
So before we move on to Catherine's portion of the presentation, if you have any questions for Sarah, can you please enter them into the chat box or the Q&A box, and I'll start sharing them with our presenters. We have her for a few more minutes. I know earlier, I think someone wanted a quick 101 on some of the acronyms.
Oh, I'm so sorry. I live in a world of acronyms, and it took me a long time to get them, so I can help you guys. TTS is Technology Transfer Specialist. TA is Technical Assistance. Triple AP is, I'm not going to remember. It's American Academy of Addiction Psychiatry, I believe. Yeah, that's the points for me because I can't believe I remembered that. I also don't remember SAMHSA, so please don't ask me to do that one. I never remember that one. If there is a specific acronym that you would like help with, you can put it in the chat and I'd be happy to translate it for you.
And then the next question is there a cost to partner and receive help with coalition work?
No. You guys, the best thing about us is that we're free. So you can work with us and you can get all of this training and education for free. CADCA, close your ears, because you can put in a request to work with CADCA through us, and then you can get that training and boot camp for free. So just, our goal is to provide the education. So if we come in person or we do anything, we pay for the consultant, we pay for the consultant's travel, we pay for their meals. We pay for their lodging. The only thing you got to do is provide space and snacks.
That's a great deal. The next question is, how do we find out what region we are in? If you want to go over the regions that,
Oh, God.
whatever you remember.
Okay, so I don't know all of the regions. I'm so sorry. But there are 10, right? And they line up with Human and Health Services. So, Catherine, what region are you in?
Couldn't tell you the number. I was just gonna say, when you submit a request, you'll find out what region you're in, because it'll go to the TTS.
Yeah. So like, that's why I don't know where everyone is, because when you put it in, it just goes to that person. So I will never receive a request from somebody in Missouri. I will say that sometimes we have gotten requests that have been transferred to us because the place of business is in Oregon, but they live in Texas. So like, that is something that happens. But that's very complicated. So you don't have to worry about that. You let the TTS worry about where it goes.
And this was posed in our Q&A box. What if you're not a CATCA member? And Sean did answer. If you want to expand on this, the grant services are available to anyone within the jurisdictions of the US. Did you want to expand on that, Sean or Sarah?
Absolutely. The grant was originally designed to serve all of the state agencies. However, right as we started accepting requests in 2018, we made that pivot. It is absolutely open for anyone within the US doing work in prevention, treatment, recovery of opioids or stimulant use disorders.
Okay. Before we move on, is there any other questions anyone may have for Sarah before we move on to the second part of our presentation? I'm going to do a quick.
Before we lose Sarah, she's particularly adept at this final question we have in the box for now. Are they the same as the technology transfer centers? Could you answer that, Sarah?
We are not. Okay, so we are partnered with the ATTCs, but we're what they do is they look at a community and they decide what kind of education and training they think they need, and then they go out and they provide that training. Our group is request driven. So you put in a request, we come to you and we provide that specific topic that you're looking for. So you're looking for like an opioid 101 training, because not everyone is on the same page, and you want them to understand the crisis. How did we get here? What's going on with it? And then like explaining the different types of treatment options and the medications that are used, right? So like, we come in and we'll specifically provide that information for you. We are partnered though, like we live in the same building. If we actually worked in a building, I could wave and say hi. But you know, that's kind of our relationship with the ATTC.
Okay, I think that's all we have. Sarah, if you want to leave your contact information in the chat box before you leave us. And I just want to say special thanks. You are a wealth of knowledge, and I hope you get 1 million TA requests out of this.
Oh, there is. Oh, somebody's asking about West Africa. We unfortunately can't do West Africa. I really wish that we could. But I know that we have an international sort of person. So they might be able to provide some resources for you. I mean, don't say I told you to do this, but I would put a request in and see where it goes, and then see. No, how about Greece? Yeah, we do the US. I'm really sorry. I wish we did other places, but we do have somebody who can try to find some resources to help.
Right there. Well, thank you, Sarah. I'll make sure to put your contact information in the box as well. And I want to kick this to Catherine Brunson, a CATCA trainer who is our subject matter expert when it comes to opioid misuse. Catherine, take it away.
Let me unmute myself. First thing I was going to do was I saw Nigeria and I saw Greece and some places, and I was going to say, sorry, it's just the United States, but I'm so glad Sarah said, never hurts to submit one, see where it goes. We try to help everyone as best we can, and we welcome you to be here with us. My name is Catherine Brunson. I'm a regional overdose prevention specialist. I started in the primary prevention coalition field 20 years ago, and then in the last 6 years, I've been working in harm reduction, and I've also been working with coalitions with CAGA for about 20 years. So I'm really excited to be here today. I've been providing some technical assistance both through CADCA, as well as the Opioid Response Network. And so what we want to do is just talk a little bit about assisting you in identifying what some coalition priorities might be and your challenges that could benefit from some technical assistance from the Opioid Response Network. And I'm going to work really hard not to use acronyms. It's so easy to say ORN. So at the beginning, and I was reading as you all were signing in, one of the things I wanted to ask you was, why are you here? That's how I always like to start. And I saw that several of you, as you were putting your various locations throughout the country and outside the country, putting your jobs and some of the things that you were looking for. And it's really hoping that at the end of the day, you'll feel like the Opioid Response Network is a place that you can turn for some assistance. So starting out, I just want to hear, what are the priorities of your coalition or community as it relates to preventing opioid misuse? Have you been working on public awareness campaigns, addressing youth risk and behavior protective factors, engaging parents, changing community level environments, or advocating for policy or system change, or other? And if you put other, I would love for you to type in the chat box and kind of tell us what some of those other strategies are. So I see you all jumping right in. Thank you. We have such a short amount of time together, and we try to push as much as we can in. Looks like we're getting really good broad section of what you've been working on. We'll give it just a couple more minutes. We'd like everyone to participate, but it's just to give us kind of an idea of where you are. So we'll give it about 10 more seconds, and then we can go ahead and close the poll. So it looks like the majority have really been working on public awareness campaigns, addressing youth and risk and behavior factors. Surprised a little bit about how many are working on the engaging parents, which is always very, very challenging. Changing community level environments. We always like to hear that environmental work, a little bit on policy change, targeted capacity building. We will talk about that a little bit more here in just a minute. For those that put other, can you share some of the strategies you've been working on in the chat box? Positive community norms messages. Yes. Okay, good. Narcan to law enforcement, drug prevention, education. So a little more on the harm reduction side. My house. I love it. I love it. Well, thank you, everyone. Just kind of wanted to get a gauge on where we are as a group right now. So we'll close that out. Trying to close it out. So we originally had thought we might be able to have a discussion, but since we have so many folks on here today, we're going to have to stick with using our chat box. So what have been some of the challenges that you have faced in achieving your goals? Whether it was working on those community norms campaigns, whether it's working on risk and protective factors, any of those areas that you answered in the polls, what are some of the bigger challenges that you've had in achieving your goals and objectives? Because I imagine they're probably really similar. So we've got several folks doing the naloxone training and distribution. Good implementation, getting parents to show up at events. Duh, we all have that one. Yes. Biggest challenge is getting parents to show up. Youth-led educational campaign, parent attendance. That's why I was surprised so many of you were working on that, because it's difficult. Anyway, a lot of resistance for harm reduction strategies like needle exchange. We're slowly evolving in our communities. Limitations on secondary naloxone distribution and other harm reduction. Getting parents interested in the topic, it's not my kid. Wow, okay, great. All of these, I'm excited to hear about these. Refusal of listening, how to outreach help tomorrow is International Overdose Awareness Day. Yes, it is, and I hope a lot of you are going to be participating tomorrow is International Overdose Awareness Day. I am going to be a very busy girl myself. So it doesn't matter what substance we're trying to address in our community. With every single substance, we have to break it down and look at it individually, because addressing underage drinking or marijuana is very different from addressing our opioid use and stimulant use in our communities. So we first have to identify what is the focus of what we're going to try to develop some comprehensive strategies around. What is the drug? We need to identify specifically. We can't put prescription medications and heroin and lump them together to develop strategies, because although they're both opioids, they're going to look very, very different. So we need to identify specifically what is the drug that we're going to be trying to address, how much of it is used, how is it used? Are they orally taking it? Are they snorting? Are they injecting? What is the pharmacology of the drug? Then we need to look at the setting. Where, when, and how is it being used? What is that physical environment, the social environment where it's being used? We need to consider the economics of it. Are people using and selling in a way to support their families? Is it an economic survival for the family? When we get in our rural communities, there's also very often very cultural specific issues that we need to be aware of. Addressing heroin use in Nashville, Tennessee, I'm in Tennessee, is going to be very, very different than addressing it up into the mountains of East Tennessee. They're going to look very different, and so our approaches will need to be different. We also need to be thinking about the emotional background, as well as looking at the mindset of the individual who's using. What are their demographics, their social characteristics, their physical and mental health characteristics, their interpersonal skills? If an individual is not getting their human connection needs met, they will bond with something, and very often drug use fills that void in our community. So we need to really take a deep dive into understanding the drug, the setting, and the set of individual characteristics that go along. So if you haven't done this yet around a specific topic that you are trying to address, and now we've added, fentanyl and xylazine and nitazine and all these other new novel substances that are coming into the question, then you need to have a coalition or a community discussion where you try to vet very specifically what is the drug you're trying to address, where is the setting, specific characteristics, local conditions in your community, and the mindset and the social characteristics of the individual that you're targeting. You need to identify those as specifically as possible if you're going to develop a comprehensive strategies that are really going to target them and hit the arrow right in the middle of the bullseye. So questions you'll want to ask are, how did you discover that you have an opioid stimulant problem in your community? What consequences are you seeing in your community because of that opioid and stimulant use? And if you have your coalition members around the table, you're probably going to hear something very different from law enforcement to public health to public housing. And so you need to understand all those different perspectives. No matter what the substance is, we all experience it a little different depending upon where we're coming from. It's important to take those into account. Who is affected and how are they affected? What are the settings? Where and when is the use occurring? We always kind of say, can you take a picture of it when we're trying to diagnose those local conditions as specific as possible? Because the more we can be, the more creative we can be about developing a comprehensive strategies to address those settings. What data or indicators are you using or could you use to measure and monitor opioid and stimulant use? Have you talked to your coroner's office if many of you are working on harm reduction strategies? Are you gathering data from law enforcement? Are you getting hospital data, emergency department, inpatient, outpatient? Are you getting public health data about your HIV, hepatitis C rates? You know, what data are you using, but also identify and brainstorm data indicators that you could collect and bring to the table. And then if you're addressing some of the new novel substances that are coming on, how is the use of fentanyl and xylazine, nitazenes, and the consequences similar or different to opioid prescriptions and heroin use in your community? These are just all some sample questions that you need to have at your table before you jump in to implementing strategies and activities. You want to make sure you diagnose the issue as specifically as you can so that you're not wasting both manpower resources as well as grant money resources doing something that isn't going to hit the nail on the right place. So I've been doing technical assistance with the Opioid Response Network with CADCA, as well as locally for 25 years or so. And no matter what topic somebody comes to me and says they need assistance with, membership engagement always seems to shoot right up to the top of the ladder after we get talking for a little bit. So what I often hear from folks is they come to the meeting, they eat our turkey sandwiches, we offer them opportunities to be engaged, but can't get folks to do the work. Does this sound familiar to everybody? Kind of a show of hands? Yeah, it's really, really common. And it's a challenge that all coalitions have. It doesn't matter if you've been around 1 year or if you've been around 20 years. As soon as there's some turnover in a coalition, and it might be in the community, your police chief turns over, your elected officials turn over, your staff and your coalition turnover. Membership engagement doesn't have a start or an end. It's a constant challenge that all of us need to be working on. And if we're going to develop that comprehensive set of strategies that's really going to change those community conditions in our community, we need to have all those sectors at the table. Easier said than done, I know. So when someone tells me that they're challenged with getting folks to do the work, or how do you get engaged law enforcement? I mean, this is an opioid crisis. So how do we get the hospitals and the practitioners and the healthcare people on board? What I always ask them is, tell me what you do for them. I will suggest to you that you will be immensely more successful in recruiting and engaging individuals if you first offer to do for them before you ask them to do anything for you. Volunteer with their efforts, recruit volunteers, donate, money to them if you can. And I would suggest to you, one of the things you can offer them is to find out what their challenges are, what they're working on in their community, and volunteer to assist them. But think about using the Opioid Response Network, the technical assistance, to not just assist your coalition, but to assist those community partners. When you can provide a resource for your community partners, that will build the capacity of your coalition, and it will help show them that this is a two-way street. I'm not just asking you to do for me, I'm here for you too. So what have been some of the priorities of your coalition partners to address opioid and stimulant use in your community? Not just the strategies that you're trying to address, but what are some of the things that your sector partners are trying to do? Type that in the chat box if you've got some ideas. What are some of the things your sector partners are doing in the community to try to address opioid and stimulant use? And if you don't know, that's okay. So one of the things I'm going to suggest to you is you go back at a coalition meeting or community meeting and you ask your partners, what is it you're trying to work on? And what are the challenges you're facing? Where could you use some help? And try to identify if these are some areas that you might be able to say, hey, you know what? I found out about this wonderful federal resource. And oh, by the way, it's for free. Let's put in a request and see if we can't assist you. I really am going to encourage you when we're talking about putting in requests and taking advantage of this free resource to not just think about your coalition, but think beyond your coalition to all those sectors and partners in the community that you want to get engaged, and use this as a resource to assist them, which assists you. And so the good news is we talk about the continuum of care is the opioid response network can provide technical assistance all the way across the continuum of care, any area or point on there. So it is really applicable to anyone in your community. Doesn't matter where you're working. And they do have, as you saw on that slide, 40-something partners. They have some of the best experts from across this country that they can bring in and provide very tailored technical assistance. Not a one-size-fits-all, we're doing a regional training, here's the topic. If that's of interest to you, attend the training. But to actually develop something that will be specific to the very request that you're putting in. And that's really quite something, if you ask me. There's lots of things that coalitions can do to support efforts across the continuum. Even when I hear you, there's some reluctance to get into harm reduction and talk about needle exchange and things like that in the community. And that doesn't mean your coalition needs to be doing those strategies of harm reduction and treatment and recovery. But those are things your coalition can support those other people in your community that are doing the harm reduction and the treatment and recovery. But some things that coalitions can do is to start by assessing and promoting your community readiness to perhaps get into harm reduction or whatever it may be. To engage in efforts to reduce the stigma associated with substance use disorders. This is something all of us need to be doing. I've been in this field for a really long time, and I'm really a little bit frustrated that we haven't made more headway in reducing the stigma and discrimination associated with opioid use disorder, as well as mental health issues. Provide education awareness on addiction, risk factors, and overdose prevention across all sectors of the community, and how to access those treatment resources. We'll talk about that more in just a minute too. That seems to be a huge issue in most communities. Collaborate with agencies across the continuum of care to ensure that there's a comprehensive, complementary, mutually reinforcing set of strategies that are employed across your community. Again, you don't have to be doing all the work, but you want all those places across the continuum in place in your community, and you want to make sure someone is doing it and that you're coordinating your work so that it's complementary, so it's supporting those community partners. And lived experience have a seat at the table. And by lived experience, I'm not just talking about those folks in recovery. I'm also talking about the folks who are actively using substances. And if you haven't engaged with individuals that are actually using substances, you're missing out on a big piece, in my opinion, because they are some of the most key informants you will ever get in your community, far more than a police chief, I promise you. And so if that is not an area that you have felt comfortable getting into, that is a really strong area that the Opioid Response Network can help assist you in making some outreach in a culturally sensitive way and provide you with some concrete examples of how they can be incredibly useful informants at your table. So just another place where the Opioid Response Network can provide some great assistance. As I've mentioned, they can provide assistance all the way, strategies all across the continuum of care, all the way from working with your healthcare providers to give them some instruction on safe prescribing guidelines, all the way to, do you need help with regulations to establish some recovery housing in your community? It's really an open book. And so I would encourage you not to question about, is this something that they can help us with? Go ahead and submit a request and they will let you know whether or not it is. But if it's opioid or stimulant related, chances are 99% of the time, they're going to be able to help you. I won't say 100% ever on anything. Stigma, discrimination, language matters. I think all of us This work needs to never stop. It doesn't have a start or a stop point, and we need to continue to work on trying to reduce the stigma and discrimination, and to help assist our community in understanding the importance of using first person language. We don't want to label someone as an addict or a junkie. They're a person with a substance use disorder. NIMBY, not in my backyard, as it relates to opioid treatment programs. This is a huge issue as well. And so I know there is a lot of attitudes and opinions about methadone, buprenorphine, Vivitrol, naltrexone, those medications for opioid use disorder. But no matter what your attitudes or opinions, I'm here to tell you, there's really strong evidence-based evidence that it is an evidence-based approach for the treatment of opioid use disorder. So they can assist you with conducting consensus meetings or focus groups, so you kind of understand where you are in your community, what is the level of readiness. They can provide educational awareness trainings as well around the effectiveness of the medication, and they can share information, resources, and research related to pregnancy, maternal child health, and the effectiveness of MOUD. Medications for opioid use disorder, so I'm not using acronyms. They have also done a whole lot of work on naloxone expansion. I was glad to see in the chat box that that's an area where a lot of you are working in your community. And so there's a lot of expertise that can assist you with that. And if you're not a state that has the state opioid response grant, which is the federal grant that provides naloxone distribution in our communities, they have a whole lot of folks that can assist you with developing some model language or regulations to enable some naloxone to be able to be distributed in your state even without those grants. They can provide a whole lot of training on a lot of different areas, like collaborating with first responders, facilitation of the implementation and consultation to help sustain naloxone integration efforts into the community. I'm a big believer in let's get beyond our first responders. By that, I mean law enforcement and fire department, and get them into the hands of the real first responders. And to me, that's the person that calls 911. But all of these are areas they can assist you with. They've done a lot of work with practitioners in healthcare, which really is pivotal if we're going to address opioid misuse in our communities. They've done screening, brief intervention, referral to treatment. I'm trying real hard on the acronyms. Training around addiction. They have done some academic detailing, which most of you are probably familiar with, continuing medical education. Well, academic detailing is actually tailoring it to where you're providing that practitioner education in a one-on-one fashion with a healthcare professional, like a pharmacist or another practitioner or a nurse. It's not coming from the pharmaceutical rep. They also can help assist you with developing appropriate promotional materials to have in medical offices and practitioners. You know, when we go to the different sectors of our community, we all have different language that we use, and they can make sure that the language is tailored to hit the target when we're talking about healthcare. Just a simple example is I hear us in the coalition field often say emergency room. Well, in healthcare, they call it ED, emergency department. Little things like that that can tweak your resources that you might be trying to share to make sure that they're hitting on target with your audience. They have done a lot of work on medication for opioid use disorder expansion. They've done asset mapping of community resources, helping to identify community champions, leveraging points of expertise to help build capacity. Sarah talked about that. We can't do some of this technical assistance you may need until we kind of get that capacity in place. They've done a lot of work on providing training on evidence-based practices to treat patients with opioid use disorder using those FDA-approved, Federal Drug Administration-approved medications, as well as some general training regionally around stigma reduction, substance use disorder, opioid use disorder. I was really excited over the past couple of years that CADCA has embraced this as well, and realizing what a critical factor it is in our community, and that coalitions can be a part of medication for opioid use disorder expansion. So we've had a couple MOUD, I'm saying it now, academies where we had some select coalitions throughout the country that participated in learning a little more about addiction, about the efficacy of those medications, And we had see incredible results and inroads in our communities. Some of the coalitions in a very short amount of time, one came back and said, you know, we didn't have any providers in our community. And now we've met with our healthcare providers, and our emergency department is going to start treating for those medications in the emergency department when they show up from an overdose example. We've had a lot of folks who have come up with some really creative ways to increase access to those treatment resources by expanding the transportation networks that exist in the community. And that was one of the biggest things that we saw. Is for those of you that have been through an academy or a boot camp, remember the drawing of your maps that we have everyone do? So we asked them to draw their community maps through the lens of treatment and access to those medication for opioid use disorder treatment resources in particular, but mapping all treatment and recovery resources. And so what came about really quickly was there were huge geographical gaps in people to be able to obtain those services in their community. And so they developed some really great creative ways of how to get around that and how to help make people aware of how to access those resources, not just individuals that needed them, but also resources to help teach primary care providers or hospital providers on how to be able to make that referral source. So I would suggest that's another area that's really good to do with your community. Trying to address something is go back to those community maps and draw them through the lens of what it is you're trying to target. And it's a really great way to turn a coalition meeting from reporting out to getting people engaged and actually doing the work. When they're engaged in doing something more than listening to people report out, they're more likely to take some ownership and get involved. Most of you should be very familiar with the 7 behavior change strategies. This is just another lens if you're thinking about what technical assistance that you might need to look through, is look at your next 12 to 18 months of your strategic plans. What do you need to accomplish? And where might you need some help? Just another way to kind of look at identifying where it is we might be able to assist you. Other ways that technical assistance can be provided is just in general, as Sarah said, coalition and capacity building efforts. And again, I don't care what issue someone tells us they need help with. Once we talk a little bit, capacity always goes up there too. So I always say that should be our number one goal in working in communities, is to make sure we build those relationships. Training on the strategic prevention framework, conducting community assessment, which can be kind of tricky for some folks, cultural competence, community mobilizing, policy or system change, anything that you can think of that's opioid or stimulant misuse or overdose related is something that the Opioid Response Network can assist you with. So I'm going to ask Sean or Samantha if you will drop in the chat box the agenda that I provided. I'm just want to, for those of you that might be new to the field, I know a lot of you probably have more expertise than I'll ever dream of and could do this better than myself, but I wanted to provide just a little bit of a framework for you to be able to take this back to try to identify what might be some benefits of submitting a request to the Opioid Response Network. And so I put a sample agenda together with some suggestions on how to facilitate that conversation in your community that I feel free to tailor it and use it if you think that would be helpful. Is here's your coalition agenda. Always make sure you have an agenda or don't have a meeting, but you're welcome in introductions, identifying your coalition priorities and challenges. First, introduce to them what is the Opioid Response Network Technical Assistance Initiative. Show them that in writing so they understand. Then provide a list of your coalition priorities relating to preventing opioid misuse. Go ahead and have those on the agenda, those top items that you as coalition need to get done. But then start by facilitating a conversation with them to identify their sector priorities across prevention, treatment, and recovery. How I like to do this is I'm the biggest fans of flip chart paper and Post-it notes, is provide individuals with a Post-it notes and tell them you only want them to list one topic per Post-it note, and put a piece of flip chart paper up there and ask them, give them some time to identify their priorities and ask them to post those to the flip chart paper. Then put another piece of flip chart paper up and ask them to take those Post-it notes and identify the challenges that they have in achieving their goals and objectives. Once those are all exhausted, and you've identified, they've identified everything, you can use markers, you can give them 2 or 3 stickers, but ask everybody to get up and go to those flip chart papers and identify what they think are their top 2 or 3, whatever number you want to pick, however many you want to address. I wouldn't go more than 3, but identify what those top priorities are. And then verbally get consensus that these 2 or 3, everyone seems to feel really strongly, these are something we need to work on our community. And so get that verbal consensus. You might want to ask them who might individually benefit from opioid response network and technical assistance, a discussion in closing, and then your adjournment. And so if, I'm getting a message, my internet connection's unstable. Hopefully you can hear me. So if at the end of that, you feel like there is a solid area for you to submit a request to the Opioid Response Network, then do that. So kind of in closing here a little bit, want to ask you if anyone kind of feels like they already have an area where you think you might be wanting to make a request, and I encourage you to go back and talk about it. But I want to reiterate a point that Sarah made earlier, and that is you don't need to write a book, but please don't put treatment or recovery, or she said harm reduction. Be as specific as you can, and that will help that technology transfer specialist to identify exactly what direction you need to go. That helps them narrow down who they want to reach out to as a consultant, and to be able to provide something very, very specific to you. So if you're saying in my community, they're not open to harm reduction and naloxone yet, be more specific than that. We need training around principles of harm reduction and evidence-based practices. Or a lot of you were addressing youth and risk behavior challenges. I need a evidence-based curriculum for doing youth skills, life skills for 9 to 12-year-olds. Like, be as specific as you possibly can in your request. And with that, I'm looking at our time here. I do want to stop and make sure that we've got time for question and answers before we put the evaluation up. So I'm going to let Samantha facilitate that.
Okay. The first question I have is, how would you work with opioid settlement task forces?
That's going to be different in every community. And honestly, that's not too much off kind of that agenda that I was just showing. Is no matter what you're trying to work with in the community, there needs to be someone who's facilitating that conversation. And so I would think at this point in time, most of those work groups have already been established. People are kind of already getting to the point where they've identified how that's going to work. So if you don't have a seat at the table, you need to reach out and try to get a seat at the table. And you should be at the table if you're a coalition fighting, to make sure that prevention doesn't get lost in the broad spectrum of thing, because a lot of people are really kind of pushing to that end of the continuum of care. So I would really just say, find out who's in that work group and make sure that you're a part of it so that your voice is heard.
The next question is, a person who partners with their county ROPS team, and their challenge is people to help with the trainings. How would you go about recruiting people?
So I don't know what ORPS is, since we're on our acronyms.
ROPS, and that was from Dana Reno, if you want to share what that acronym represents. But her question was recruiting people to help with trainings.
So are you trying to recruit the trainers, or are you trying to recruit people to attend the training? So if you're trying to recruit the trainers, this is the perfect example, is something both CADCA and the Opioid Response Network can provide, is they actually provide trainers that come in on the topics that you've identified that you need. If it's you're trying to recruit people to attend the training, that's kind of almost a bigger challenge. And it's just really a matter of doing targeted outreach, making sure that you're not just relying on an email going out. I mean, you need to do social media, but I've got 5 events in 4 counties tomorrow. We sent snail mail invitations to a lot of people, particularly if you're wanting your elected officials and some of those more formal leaders. It's a very different outreach than if you're trying to reach some youth at some kids. But I always say, rarely is the coalition staff person the best person to make an ask. And I don't care what the ask is, whether it's about fundraising, whether it's about capacity. If there's someone that you're trying to get at your table, identify who is the most influential person to make that ask, and you'll be more likely to be successful. It's rarely the coalition staff. Find out if they've got a family relationship that you know about, or a friend, or a colleague in their professional group. Think about who you're trying to outreach, and don't do one size fits all. Do a different outreach for youth, a different outreach for the law enforcement, different outreach for healthcare. And I would ask someone you know in those sectors, what's the best way to reach you? The best way always is just to ask folks, how's the best way to reach the rest of your recovery group? How's the best way to reach some youth in the school?
Dana was nice enough to respond back with the acronym. It means Regional Overdose Prevention Specialist.
That's me.
We knew that.
So what was the question? Oh, getting people to attend our training?
It didn't expand, but Dana, if you want to expand on that question, you could just put it in the chat. We can move on to the next question.
Well, I was going to say, you can also, Sean put my email address in the chat box. You can contact me personally. I've already done 2 ropes trainings this morning before this. So I will be happy to talk to you about that on a one-on-one if you're in my state or around afterwards, because I know we're short on time.
Thank you, Catherine. The next question is, how would cultural competency be met at all trainings or all meetings?
That's kind of a broad request. So I think you'd probably, if you're trying to make sure that each one of your meetings has a cultural competence included as a baseline, and it should, is to first start by making sure your coalition and staff have all had sufficient training around cultural competence. And that doesn't just mean training by CADCA, training by ORN, but after you get that training, making sure that those people that you want to be culturally competent with are sitting at your table. And once again, I always go back to asking them. It's been several years now, but when the binary discussion came up in our coalition, and I was kind of like, because I'm old, and so we had a AmeriCorps worker who was working with us. And so I simply just asked, would you mind sitting down with me and helping me understand this? And so I think most people are very willing to share with you because they want to be understood. So my best way to get around every challenge is not to think that I'm the expert, but to go to someone else and just ask them. And I don't think I've ever had anyone say no, to just asking a simple question. Can you help teach me? Can you share some time with me?
That's all the questions I have. Does anyone want to enter in anything else to the chat or a Q&A box before we share our survey link and close out for today? I don't think I see anything else, Catherine.
And I was trying to rush to leave some time for questions at the end. So.
And if something comes up, I'll let you know, Catherine. But I mentioned earlier during the webinar, if you would like a participation letter, this is our survey. We'd love to hear back from everyone. So if you're interested in having similar topics on our Wednesday webinar series, or just what you thought about the webinar in general, we really appreciate your feedback. And if you have any questions, the presenters, I know they shared their emails, and I will share my email as well. Everyone should have it, but if you have any questions, feel free to ask and email any of us. So we're going to leave this up for a few minutes, and then we'll close out for today.
Yeah, and I'll stay on. I always say I'm in the room when I'm doing training personally, or when I'm on virtual. I always say I will be the last person in the room. And if you don't feel comfortable, staying on talking, I'll get in touch with you afterwards and we'll connect with you. Thank you all so very much for attending today. And I certainly hope that gave you some food for thought about thinking about how you can facilitate the conversation in your community, and that you identify some ways that might be beneficial for you and your community partners. Thank you all. Coalitions rock.
Mirla, thank you. Very sweet people. Very sweet people here.
Oh, IOM, I'm just seeing that. Institute of Medicine. I tried not to do any acronyms. I didn't get that one. Institute of Medicine. Oh, someone put it down. Thank you, Heather. Samantha, will you be sending out the evaluation link too? Someone says they're trying to get to it and they can't.
It should be also in their follow-up email. Everyone who registered for this this webinar should have received emails with the link. There should be as well follow-up emails with the survey. If not, everyone should have my email and I could send it to them individually. It happens every webinar where worst comes to worst, just reach out to me.
And again, thank you to everyone for attending.